Well, great. Thanks so much. So thank you, Antonio, for the gracious invitation to speak. And I'm going to say quickly before I start something that we've all been thinking while we're here, which is to thank Danilo and the team. Every detail of execution, of organization has been perfect. Yeah. So very good lookout for Sardinia and Unica, yeah? Okay, so Willie Sutton was a famous bank robber in the U.S. around 1950, and he finally got busted, as bank robbers often do. And after that, in jail, someone asked him, well, why did you rob banks? And he said, well, because that's where the money is, right? And what I want to do with this talk is argue that if value is saving lives, making healthy mothers and babies, and improving life on Earth for people with our time and skills, then the global South, low middle income countries, those contexts, that's where the money is, okay? And like bank robbing, there are built-in obstacles to succeeding at this cash-in, and so I want to go over some of those obstacles and then some potential solutions. And I also now will give disclaimer. I am part of Global Health Labs. We are a very small lab funded by Bill Gates, like 80 people, I think, technical lab. And so I do machine learning, data analysis, and signal processing. And our job is to provide technical support as needed to the Gates Foundation, which is a very big organization, right, also funded by Bill Gates. And Amy Schellpfeffer, some of you are familiar with, is a program officer at the Gates Foundation in the maternal and neonatal children's health group. So she was unable to be here. She provided some materials for these slides, and if there is telepathy, she's at this instant snapping to attention and hoping that I don't screw up what she gave me. Okay, so here's the basic context. We have labor in rich countries. It's a little inaccurate because there's only one caregiver, but here's the mom, and here's all this gear and care, and she's going to have probably a pretty good trajectory. And this is a context in a place like sub-Saharan Africa. I don't know which country this is from. But the key is that some of these geographies, they simply don't have the money, they don't have the facilities, they don't have the gear, they don't have the trained personnel. And the result is the care is much worse, okay? This is a reality, and it's for most births in this world happen in these contexts. So unfortunately, this presents a huge opportunity because if we can make changes to how care is delivered here and change the resource base, then a lot of people can have much better lives. So as an example, these are some plots from the foundation. And, deaths are easy to measure. But let's remember that every death it's like the tip of an iceberg of suffering. And there's this little thing at the top we can measure easily, but there's this huge piece below. And on the left, in blue, are current maternal and neonatal deaths. And one thing I'll say about these neonatal deaths per 1,000 is that I think there were like 65 people who signed up for this conference. And roughly speaking, that means that if each one of us, or our partner, was in these geographies and gave birth, all of us on the same day, then one of us would come home without a child. Pretty much guaranteed. Maybe 2, maybe 0, Poisson statistics, but that's what they're dealing with. So on the right, we see the gains that can be made if we can intervene appropriately here. Okay, so that's kind of the agenda of the Gates Foundation. And to narrow it down to this conference, there's a lot of things that go into improving that situation, right? A lot of different things. One little piece of it is that monitoring does not happen here. Derek was just telling me today that in Ghana, what is the uterine contraction? The nurse puts her hand on the abdomen and counts, and that gives the contraction timing, right? And so in bold font, you see why all the money is down in LMIC contexts. The bullet points, both for the neonatal and for the maternal, show that these are problems, these are causes of morbidity that sensors can detect and can allow us to respond to. So this is a case where sensors can make a big difference here. And that's why the foundation sees a key role for devices and algorithms, okay? So they've placed a bet. You hear at the foundation, a big bet. That's one of their terms, right? When they put a lot of money into something. In the notion that if we can develop devices, and there's this revolution now in wireless devices, robust devices, low price point, that can actually suddenly be deployable, right? It's not the CTG we use here. It's devices like that wearable sensor from Cybele on the woman there that collects the woman's vitals, right? Vital signs. And plus algorithms, and if these can be combined, then they can provide decision support and the vitals that people need to make good decisions. And I'll take you back to that picture with the crowded labor ward. What you have there is a whole bunch of people having babies and not enough staff to take care of it. So one basic question is, if you're the provider on that ward, there's a lot of OBs here, right? If you are the only OB on duty for these 60 women, you want to know who's doing okay and who are the critical cases. And if you imagine each of these women had some sort of wearable, robust patch that could track what they're doing, that allows triage and allocation of resources much more effectively. So that's an example of how this could make a tremendous difference. So the foundation is super keen on this. And there's always a catch, right? So this is a great gain to be had, but there are difficulties. And of course, there are a million difficulties to making this happen, but here are three that I'm going to pick out that are specific to algorithms and the kind of work we do here in this conference in no particular order. And so I'll walk through these and then offer some possible paths forward. So first of all, the algorithms, the tools have to be fit to context. Now, say what you will about the Pinard horn, right? It's been around for a couple hundred years, but it has maybe limited signal it gives, but it always turns on when you press the on button, right? It always works to some degree, and in trained hands it works pretty decently. On the left, you see a CTG, and our Carolina, is that right, from Brazil, was saying how you have to save paper in Brazil. Well, this was one in Kenya where they have no paper. So this CTG has no value whatsoever, right? It is the wrong tool for the location. It's not robust to it. And this is true also of algorithms. Okay, so now I work in the machine learning space, and we, at our lab, one of our rules is we always are working on very focused medical use cases. And so all our work is focused on medical use cases. We see in the machine learning world, algorithms are shaped by the forces that people are driven by. And in the machine learning world, those are all intra-ML forces, right? You have to have lots of math. You have to have the fanciest algorithms. You have to have a comparison to your peers on curated data sets. To get published, those are the incentives, and that's what shapes the algorithm. And you end up with something on the right. But a medical problem is like on the left. And so I was complaining to my neighbor how hard it is to get machine learning algorithms that can actually work in the field, can be deployable. And he's a doc who does a lot of work in Kenya, and he works with women's health clinics and HIV research and vaccine trials. And he said, yeah, there's just a lot of interlocking pieces that all have to go together. And so a medical problem is all these interlocking pieces, and there may be an ML, an AI part, an algorithm piece of that, but it has to be shaped by forces that are from outside machine learning. They're outside our silo. They're coming from the use case. They're coming from the clinicians and from the needs. And if that algorithm is not shaped correctly, it will not work. Okay, so it will not be a solution that's deployable. And this is true for machine learning in general to healthcare, but it's also a corollary is that if we do this perfectly and develop a perfect solution that fits the jigsaw puzzle of a rich country context, if the context in a low middle income country is different, then that jigsaw puzzle will be the wrong shape, okay? And it will not work. And I'll give a couple concrete examples of this. For example, anything that increases the cesarean rate is going to be a non-starter in a lot of these contexts. We were talking to some OBs in Nigeria, and they say, yeah, when we have to do a cesarean, we have to cancel planned cesareans to allow the emergency. And in fact, there's often no blood for the patient. So if you're expecting surgery, you need to bring a family member to supply blood for your surgery. So, and they only have, maybe they have one theater. I guess they have one operating theater they can do cesareans in. So they can't, the resource base won't allow certain kinds of extra interventions. And another example I would give is Austin's amazing insight that there's certain things. Where is he? Is he? Yeah, yeah. So there are certain things we can measure, and certain things that we, as a silo, as a culture, as a group, will do because we've always done them, and this is what we do, and we can measure it, and we can get results, and the results are meaningful to us. But there's the clinical need, which can be totally different. And the algorithms have to accommodate the clinical need, wherever that is, and whatever sensors we need for that, right? So this is step number one, a crucial thing for success. And number two, of course, to make data sets specific to these use cases, we need data. Or to make algorithms, we need the data, right? And the foundation is committed to this. So, a person's a person, but these populations can be very different depending on their what's happened to them in life. And so these issues, anemia, malnutrition, for example, less antenatal care was referred to with ultrasound. These are realities, and these make very different populations and different algorithmic needs, if you like, for solutions. And so the foundation is sponsoring, along with others, helping to develop data sets specific to these low-middle income country contexts. Okay, and I'll give you some examples. I've worked on all three of these. The Vitals was 6,000 or 8,000 women in Pakistan. I think there were some other sites as well. And they just collected all the clinical input for women coming in for labor to see what the background context was. Labor is a study that's just winding up. We're just getting the data organized. This was 12,000 women over in Ghana, Zambia, and 2 sites in India, where they collected for everything that happened during labor, from time registering at the hospital, time out. And they had all the labs and the clinical intake data, plus they had a scribe by bedside to write down whatever happened, medication, blood pressure, temperature happened, doctor decision, this. And they had sensors attached, the Cybele sensor that you saw earlier, another limb sensor to allow some other, SpO2 for example, and transabdominal ECG electrodes on every single mom, okay? And in particular, these readings, they give the EMGs for the uterus, and they also give fetal heart rate, they give uterine activity. It was the study, the women received the standard of care, which means the caregivers did not use this CTG. They didn't even see the CTG. So actually we have several thousand women where we have the CTG and it did not affect the outcome. So we have outcomes independent of intervention due to CTG. Okay, so this is a study we're working on now. I3P is going to be, intelligent pregnancy product platform. And the idea is to see if you can get a suite of sensors that can all work together and be functional in a labor setting in some of these. That's going to be in Pakistan, Kenya, or Nigeria, and India. And that's just starting up now. So I won't dwell on these except to note that the Gates Foundation, all data sets become public for responsible use. That's part of the shtick. It's open data. And so and these data sets are no exception. It takes a while for them to become available, and there are constraints, but fundamentally, if you're a responsible person, these will become accessible, right? I do want to mention just Vitals, just to give a little context. So this data set, well, again, Pakistani, a fishing town, small, 250 kilometers from the nearest hospital, almost no antenatal care. And I was going through the statistics, doing my data analysis thing, and I suddenly realized that one way they measure nutritional status is mean upper arm circumference, middle upper arm circumference, okay? So there it is, you measure that, and I looked, and the median for these moms coming in for labor was this, like the size of my wrist, and they were coming in to give birth. And the other thing that happened is they have a very high stillborn and neonatal death rate there. And part of the study was that, they have forms, and you have a certain study, and you collect data. If the baby was stillborn or died, then there was an extra form. And one of the things on the form was an interview with the mom. And they would ask, if you'll answer, what did you experience? How are you feeling? And so you read, and each mom has a page, and you read it. And I was getting all these headaches, or, suddenly I started bleeding, or the doctors became very concerned. They have no idea what was going on, but something bad was happening, and how are you feeling? They're resigned, they're sad, they're the will of Allah, they're empty, they are heartbroken, and you read that, and then you turn the page, and it's a new PDF with another, and there's another, and there's another, and there's 180 of them in this data set. So there's just a world of unnecessary suffering that's going on here that we can make a difference in. And the third thing that I want to mention here is intentionality. And this is the CEO of Gates Foundation about AI. It's almost a law of nature, right? That when something new comes out, it always seems to be the rich and the people who have that get it, and the people who don't have to get left behind. And actually, came to us. Someone came to speak at our lab, Dr. Hema Mage. She was doing logistical, like systems modifications at hospitals to improve prenatal care and labor in Ethiopia. And she says, even the best of intentions, we're going to these 5 hospitals and deploying, but some hospitals it sticks because they have just enough training, just enough resources, a little extra bandwidth to make that system change work. And so it's succeeding there. These other hospitals just don't quite have the bandwidth. They don't have the key people. They don't have enough money. They're a little too far from the supply chain, and it's not working. And unless we're super intentional, she said, we just end up going with the hospitals that were making it work, and the ones that couldn't quite pull it together get left behind. And so this intentionality is crucial to constantly be turning away kind of from the easy path that's working to something that's not working. So those are the 3 big thoughts. And now on the analogy of where the money is. So I didn't actually randomly come to Sardinia and be outside and wander in Monday morning because I thought there was free coffee, right? Amy suggested I come here to learn, and because this is where the money is, right? For the Gates Foundation to follow through on this agenda, which has potentially huge gains, we need experts in monitoring, pregnancy monitoring, and algorithms and sensors to intentionally seek out these opportunities to tackle these challenges, to analyze these specific data sets that the foundation is generating, right? Because it's a lot of complex data, so is someone willing to do this? And to ensure that by their designs, these solutions will work in the LMIC context. So that's the pep talk, and thank you so much for your time and energy. And ping Amy, ping me with any questions, ideas, etc. Thank you.
Thank you.